Good morning, everybody. Welcome back. I'm so happy to meet you again in this very important project, B-lines in the emergency room and the ICU. Recently, I was asked to assess a 58-year-old obese female patient known case of long-standing hypertension and diabetes, controlled with metformin, calcium channel blocker, and beta blocker. She has complained of gradual progressive dyspnea since a couple of weeks, associated with dry cough, orthopnea, paroxysmal nocturnal dyspnea. She asked medical advice and received diuretics with a slight improvement. She is obese female with body mass index 36, fully conscious, oriented, cooperative, heart rate 90 per minute, sinus, blood pressure 140/90, O2 saturation 85 on room air with respiratory rate 27 per minute, heart examination S1, S2, chest examination mid and pedal crackle, abdomen distended and lax. We started advanced critical care ultrasound to know the cause of patient dyspnea. First, inferior vena cava. As all of you know now, I usually start by inferior vena cava in advanced critical care ultrasound. Inferior vena cava of our patient is narrow, totally collapsing, narrow, totally collapsing, denoting normal right side pressures. After that, we go to the heart. We start to assess the left ventricular function of the patient by visual assessment, four-chamber view. As you see, good shortening and thickening of the lateral, anterolateral and the inferior-septal wall, and good upward movement of the lateral annulus of mitral valve here, and right side is not dilated. It's almost 60 to 70% of left ventricle, and the tricuspid annulus here is going properly in upward direction. A visual taps here is okay, and no pericardial effusion. We put the pulsed wave Doppler here at the lateral annulus of mitral valve to do the tissue Doppler of the lateral annulus of mitral valve here. As you see, we can determine the upward movement of the lateral annulus of mitral valve here as evidence of ejection fraction in our patient here. The S prime, which is the upward movement of the lateral mitral valve annulus, is 10.6, which is good, normal up to 8.5, good. And putting the pulse wave Doppler here as the LVOT to determine the stroke, the LVOT VTI, which is the surrogate of stroke volume of the patient. As you see, the LVOT VTI is 22.9, very good, super normal, and it is the surrogate of the left ventricular stroke volume. So LVOT VTI is normal, good ejection fraction. And we should apply the color to exclude the left side valve lesion as a cause of dyspnea in our patient. There is very mild mitral regurg, good contraction here, and putting the continuous wave Doppler here as an aortic valve. The VTI of the aortic valve here, tracing by continuous wave Doppler, reveal normal peak systolic velocity and normal mean gradient. That means we don't have in our patient a significant mitral regurg or aortic valve lesion, left side valve lesion, which can cause acute dyspnea and dyspnea in our patient. So, till now, good left ventricular ejection fraction, normal stroke volume, no significant left side valve lesion, no pericardial effusion. And by visual assessment also, right ventricle is not dilated, and the visual TAPSE is doing well. Attention, we are talking about the dyspnea. Our patient complains of short breath with hypoxia and tachypnea. That means even if the left side heart is doing good, is doing well, if there is good left ventricular function and no significant left side valve lesion, you should exclude a diastolic dysfunction as a cause of pulmonary congestion and dyspnea. In our patient, because our patient has long-standing hypertension and diabetes, you should exclude the diastolic dysfunction as a cause of dyspnea in our patient, and you should go to this diastolic dysfunction guidelines of the American Society of Echocardiography and European Association of Cardiovascular Imaging, and to exclude the increased left atrial pressure as a cause of pulmonary congestion and dyspnea In patient with heart disease or long-standing hypertension and diabetes and liable for heart disease, you should apply this diagram. First, you will put the pulsed wave Doppler at the tip of mitral valve to determine the E over A ratio and the E wave velocity. If the E over A ratio is less than 0.8 and the E wave velocity is equal or less than 50 centimeter per second, it's done. It is a normal or low left atrial pressure. And in this situation, you can exclude a diastolic dysfunction as a dyspnea in your patient. Second, if the E over A ratio is more than or equal to, that means the patient has increased left atrial pressure, grade 3 diastolic function, and in this situation, if the patient complains of dyspnea, the cardiac cause diastolic function is very high possibility for this dyspnea. But if the E over A ratio is between 0.8 and 2, or if the E over A ratio is less than or equal 0.8, but the E wave velocity is high, more than 50 centimeters per second. In this situation, to accurately determine the grade of the diastolic dysfunction, you should, according to this guideline, do 3 parameters. First, E over E prime, tricuspid regurg velocity, and left atrial volume index. This is very important to exclude, to know the degree of the diastolic function. If 2 of these parameters are negative, that means the patient has normal or low left atrial pressure. If 2 of 3 of these parameters are positive, that means there is increased left atrial pressure with grade 2 diastolic function. Let us apply these guidelines to our patient. First, our patient has E over A ratio more than 0.8. That means it is in the category of 0.8 to 2, you should do 3 parameters. The first one, E wave over lateral E prime here, E prime, this is the E prime, and this is the E wave. E over E prime is 4.5. To be positive point, it should be more than 13. That means we have negative point. Second, left atrial volume index. To have a positive point should be more than 34 milli per square meter. But in our patient has only 17 milli per square meter, another negative point. No tricuspid regurg, another third 3 point negative. That means the patient has normal or low left atrial pressure and the grade 1 diastolic function. At this point only, we can to great extent exclude left atrial cardiogenic cause of dyspnea. Third, lung. It is advanced critical ultrasound. Third, lung. We survey our patient lung ultrasound. Almost in all area of our patient, there is these pictures. As you see, very thick pleural line with diffuse B line. Very thick pleural line with diffuse B line. You see here, even in the lower zone, besides the liver here, diaphragm, there is thick pleural line with diffuse B line. Thick pleural line with diffuse B line. Attention, this B line has very important characteristic. First, it is thick, very thick pleural line. Normal thickness 2 millimeter. It is here in this area 3.6, and in this area it's above 5 millimeter. Very thick pleural line and diffuse B line. Second, there is at the same area, in some areas there is A line and B line at the same side. This is A line, and nearby this area of B line we find a B line with thick pleura. Another area, there is very thick pleural line with diffuse B line, very thick pleural line. And at the same area, nearby, there is A line, A line, A line. That means A line beside B line. Okay, this is a clear picture of interstitial lung disease. Thick pleura, diffuse B line, normal left atrial pressure, and no subpleural consolidation despite this diffuse B line. No subpleural consolidation. Why isn't an infection? Good. In this very important recommendation, international evidence-based recommendation for point of care lung ultrasound, which done 2012 and published in Intensive Care Medicine, and done really by the founder of lung ultrasound, Dr. Giovanni, Professor Daniel, Professor Berberi. This is very important recommendation really. They mention very clearly, in contrast to cardiogenic pulmonary edema, the sonographic findings that are indicative of ARDS inflammation to differentiate between a congestion and inflammation as a cause of P-line, you need to search for these signs in lung ultrasound. Anterior subpleural consolidation, absent of lung sliding, spurred area of A line beside B line, pleural line abnormality. This is very important. As you see, here there is subpleural consolidation going with ARDS. Here the pleural line is very thin. No subpleural consolidation. You see here, very subpleural consolidation with thick fragmented pleura here, subpleural consolidation, decreased sliding with very good sliding with P line here. You see here, very clean and clear and thin pleura with diffuse P line, and there is subpleural consolidation. This black area under the pleural line is subpleural consolidation, denoting an inflammation, denoting an acute inflammatory process behind the pleura. You see, very thin pleura and subpleural consolidation here, denoting inflammation, and here is congestion. Subpleural consolidation and thin pleura. Subpleural consolidation and thin pleura. Here, diffuse with no spurred area or the area B line. Here, there is B line with nearby A line. B line with nearby A line. At the same lung zone, B line and A line, going with inflammatory. Okay. Our patient lung ultrasound didn't reveal any subpleural consolidation despite extensive diffuse B line. This is very important. If you don't see any subpleural consolidation despite diffuse extensive B line, you should think of other process other than inflammatory. Think of pulmonary fibrosis, especially if the pleural line is very thick. And explore more area. We explore more areas, more important areas in our patient history, reveal recent exposure to new domestic bird. And this is some publication which denoting the importance of very thick pleura in the interstitial pulmonary fibrosis. This is some I found and searched and found this publication. It's going with, and in these articles, B line and the average thickness of the pleural line as the lung ultrasound marker of fibrotic interstitial syndrome are highly and positively correlated with high resolution CT. So, very thick pleura and the diffuse B line without subpleural consolidation, be alert please to consider pulmonary fibrosis or evolving pulmonary fibrosis. We did high resolution CT for our patient and reveal very thick septa here, very thick septa, very pulmonary, denoting pulmonary fibrosis, interstitial lung disease, very thick septa, and ground glass appearance, very prominent ground glass appearance, thick interlunar septa. Thanks to advanced critical care ultrasound, which help us in doing an accurate diagnosis, which is ultimately will lead to proper treatment and cure. Patient was advised to avoid bird exposure, and after a course of steroid, patient improved and follow-up lung ultrasound. Really amazing. All the P line converted to A line with very thin, clean pleura. This thick, ugly pleura disappeared with very thin and clean pleura and A line. Also another area here, very important here, A lines all over with thin, clean pleura. But there was still really P line at the basis and thick pleura also here in this area, thick pleura with P line, thick pleura, but almost all the lung became A lines with clean pleura. Here is some B line and thick pleura here. You see, this is the first lung ultrasound with very ugly thick pleura, but no subpleural consolidation, denoting no manifest inflammation. And here is very clean, thin pleura with A line. Take home message. P lines are almost 100% sensitive to diagnose interstitial lung disease, but unfortunately almost 100% non-specific. In this very important article to compare between ARDS and cardiogenic pulmonary edema, P line present in 100% of patients with ARDS, and unfortunately 100% of patients with acute cardiogenic pulmonary edema. So if you will rely only on the P line in the ICU, believe me, it is critical and dangerous to the patient because it's non-specific. You cannot know the cause of P line with B line alone. You cannot know the cause of dyspnea with B line alone. You need to know the circumstances around this B line and the other signs beside B line, because B line present 100% of time in cardiogenic and non-cardiogenic dyspnea. So we recommend and advise this protocol. If you see diffuse B line in your patient in the emergency room and ICU. Second step, look for the packages of 3 types of P line. Take it as a package. Please, integrative approach is very important. So, B line is okay, but you need to know the history and physical examination of the patient, okay? It's very important. If it is an acute dyspnea, within hours, within days, and the desaturation, acute dyspnea and desaturation, by history, this rapid onset dyspnea is going with inflammatory, infectious, which is going with ARDS and pneumonia. In this situation, you will look for diffuse P line. With sparing, you will see A line beside P line. And the diffuse subpleural consolidation and the normal left atrial pressure is going with inflammatory ARDS. So, acute process of dyspnea and desaturation in a patient with diffuse P line and a lot of subpleural consolidation and sparing, you should think about inflammatory process, ARDS or infection. But if you have, if your patient has a subacute dyspnea and desaturation, like our patient, developed over many days, several days, or over weeks, with diffuse P line and the very thick pleura and the minimal or absent pleural consolidation, minimal or absent pleural consolidation despite diffuse extensive P line, you should alert you for fibrotic process going on, evolving fibrotic process going on, especially if the left atrial pressure is normal. But if you have diffuse P line without sparing, with smooth, thin, clean pleura, and high left atrial pressure, this will go with left side cardiogenic pulmonary edema. Okay, to know about the cardiogenic and non-cardiogenic pulmonary edema and how to differentiate between these areas of ARDS and acute pulmonary edema, I advise you to join us in our advanced critical care ultrasound in Egyptian Medical Syndicate, at 5, 6, 7 of July, next July 2025. And for anyone interested in this very important and precious course, please call WhatsApp Dr. Dua as a scientific coordinator in this mobile number. And this course is really unique because you will receive a very valuable online materials, evidence-based and case-based lectures. Before the course, you will receive these online materials to give a good time for hands-on on a volunteer to know how to assess the left ventricle in professional way, in complete way, the complete assessment of left ventricle, complete assessment of right ventricle, and the fluid responsiveness, and the best way to give IV fluids, because in our advanced course, you know how to do to measure the stroke volume of our patient. It's not only to assess the left ventricle as a ejection fraction, but also as a stroke volume of the left side, which is very important. And also in our course, you will know about the importance of valve lesions in ICU, and you know about the diastolic dysfunction, how to determine the left atrial pressure to differentiate between cardiogenic and non-cardiogenic pulmonary edema. It's very important. And you will know about the advanced lung ultrasound, rule of lung ultrasound in recruitment in ARDS, and the pericardial tamponade, constrictive pericarditis, shock protocol, and the integrative approach of cardiac and lung ultrasound for acute respiratory failure. And the very important lectures you will receive, the Doppler physics, because Doppler is the cornerstone of advanced critical care ultrasound. You will get a very valuable lecture of the Doppler ultrasound in very simple way to know how to apply Doppler for your patient. And the most important point in this course, it's not only online materials and not only extensive hands-on training, but also ICU sitting training to do it yourself in the patient, to know how to differentiate between cardiogenic, non-cardiogenic, how to know the degree of left ventricular dysfunction, right ventricular dysfunction, is it acute or chronic, and the more important point also you will learn. Thank you for watching. See you all in Egyptian Medical Syndicate, and see you in another project. Bye bye.